This program is intended to be general in nature and should not be used as a substitute for advice from a qualified health provider.
On Health Matters, it's being called an epidemic. Millions of Americans hooked on opioids, some illegal, some prescribed by doctors.
I was addicted to morphine and Dilaudid.
Ray Sanderson became addicted after a surgery left him in extreme pain.
Took them more because I had myself convinced that I was in more pain.
His road to recovery, and the little boy who keeps him grounded. The opioid crisis, right now on Health Matters.
Health Matters is made possible by our viewers, the friends of KSPS, and by Providence Healthcare.
I'm Arnie Peterson, and I'm an orthopedic surgeon, and I work at Sacred Heart for Providence Medical Group. When I needed my hip replaced, I chose Providence because of the professionalism and the care that I knew I'd receive. I never thought twice about going anywhere else.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?
Good evening, and thanks for joining us. I'm Teresa Lukens. Tonight, a very tough but timely topic, the opioid epidemic. It is straining our medical system and leaving families in shambles. In 2017, the Department of Health and Human Services declared it a public health emergency. More than 130 people die each day in the U.S. from opioid-related overdoses. Here to help us understand this crisis is our panel for the evening. Dr. Bob Lutz is the health officer for the Spokane Regional Health District. He is also a member of Spokane's opioid task force. Lora Jasman is a physician with Rockwood Clinic and MultiCare Health System. She works in the internal medicine department. Chris Greer is the pharmacy manager for St. Luke's Rehabilitation Institute, where he has worked for more than 20 years. In his time there, Chris has worked on pain management and lowering opioid exposure. And Dr. Dan Getz is the Emergency Department Medical Director at Providence Sacred Heart Medical Center here in Spokane. And before we begin our discussion tonight, a note: if you need help right away or you have a question that you would like answered privately, we invite you to call one of two numbers. During our show, you will see the number to the Substance Abuse and Mental Health Service Administration's National Helpline. That number is 1-800-662-HELP. That is a national hotline. It is toll-free, 24 hours a day, 365 days a year. Here in Washington State, there's the Washington Recovery Helpline. That number is 1-866-789-1511. It's also toll-free, operates 24/7. We will run both of those numbers during this broadcast, as well as numbers for Alberta and British Columbia. And of course, we are also taking your calls, your texts, emails tonight, and we are streaming live at ksps.org and on Facebook. And panel, thank you so much for being here tonight. It's a big topic, one we want to try to get as much information in as we possibly can. Dr. Jasman, let's first start by talking about what are opioids? What are we talking about when we say that?
Yeah, so opioids are a group of compounds similar to morphine. And we call them opioids because it includes, some of them are natural products that came from the poppy seed. And then there's some that are synthetic, like oxycodone and fentanyl. And then there are drugs that are similar that are illicit, such as heroin. And all of these compounds have some similar features, which is that they are useful for pain, and yet on the other hand, they can be abused and can cause addictions.
And why are they so addictive, Chris?
Well, they take advantage of our body's natural pain modulation systems. Have you ever heard of a runner's high? That's endorphins. And so these are naturally occurring receptors. And if you take an opioid medicine for a period of time, you become tolerant. And sometimes that's your body's adaptation to the medicine. And then over time, you might become dependent. And so when you don't take the medicine anymore, you can have withdrawal symptoms. And so those feed on each other to drive our use of the medicine, sometimes inappropriately.
Mm-hmm. And Dr. Getz, people will start taking these, they have an injury or surgery, and it's for, in many cases, legitimate pain management. So where does the turn happen? What happens in the course of, say, days or weeks?
You know, I think there's a certain number of patients where they probably experience much more euphoria than the average person, and it's that euphoria, that feeling of really, really good, that I think is what probably hooks people on that, and that's that select patient population that are really at high risk.
And typically, how long can that take to happen?
You know, and I'd defer to Dr. Jasman, but in as little as 2 weeks of regular use, you tend to see patients developing some degree of dependency.
Is that the case?
It can be. It's very variable, and it depends upon, you know, the person and their underlying risk factors and the dose and duration that they've used.
Dr. Lutz, how did this epidemic get started? And what do we know about the root of it and the populations involved?
Yeah, sure. It's complex, to say the least. If you look historically, you know, over the course of the last century and a half, we've had different waves of substance use misuse. It began back in the beginning of the 1900s when morphine was not a prescribed medication, but it was available through pharmacies. And so interestingly enough, some of the very first populations that got hooked on morphine were mothers who were encouraged to take morphine to help them sleep or to help their children sleep. Currently, what we're seeing is that, you know, back in the 90s, a lot of prescription opioids were heavily marketed to physicians, and physicians were oftentimes taught that pain was the quote-unquote fifth vital sign. So you had to be monitoring an individual's pain, and if you weren't addressing it appropriately with appropriate medications, oftentimes opioids, then you weren't taking care of the patient. So thus began this sort of incremental increase of prescribing practices. And so that pretty much is what we call the first wave of the epidemic, which went through probably, you know, maybe 2009, 2010. You had individuals then all of a sudden who became hooked on opioids, but no longer having them readily available, but heroin was readily available. It became cheap, and again, very easily accessed. And so now people were diverting from prescription medications to illicit, such as heroin. And what we've seen, unfortunately, over the last few years is that now there's been an increase in fentanyl. And so we're seeing an uptick in the state in fentanyl, but that's also been something that we've seen nationally and regionally for a number of years. And so at some level, we're a little bit behind in how fentanyl is approaching and, you know, affecting Washingtonians, but it nonetheless is present.
Chris, talk a little bit more about what fentanyl is.
Fentanyl is an opiate that's very potent, and so a very, very small amount can become toxic. But
it's a prescribed drug?
It's a prescription drug that's available. A lot of times they'll use it for surgery to induce anesthesia. It comes in a patch form. It's long-acting for patients maybe who have cancer that need strong pain control. So fentanyl is a drug that's prescribed and used. Just there's a illicit supply available, and that's causing the problem. You know, famous people like Prince had a fentanyl issue, and it's a very dangerous drug because it's so potent.
Is that where we often see overdoses involved?
Overdoses, if they mix it in a different way, a different proportion on accident, then people can accidentally overdose if they get the mixture wrong for illicit drugs.
And we'll find, Dr. Getz, that people will go to some extremes to try to get drugs, often going to the emergency room.
Yeah, absolutely. It's one of those things that I think define the disease. It's something where it's omnipresent. They never stop thinking about it, and will really do whatever they can if they need to get that next dose of drugs, and whether it's feigning illness or breaking into a house of somebody that recently passed away from cancer to try and find leftover medications. It's one of the natures of, it's a horrible disease.
What's protocol? If somebody comes into the emergency room and you see those signs, and by the way, what would be those signs, what then happens?
Protocol is really difficult because we like to give patients the benefit of the doubt, and there is a very appropriate patient population that benefits from these medications when they're suffering from acute pain. We have now in Washington State a prescription monitoring program where we can look up and access records from local pharmacies looking at prescription patterns. That used to be a big problem several years ago where patients would shop different emergency departments in the community and fill multiple prescriptions. Now we can see that, and we will confront patients with that information sometimes and try and refer them to local resources. That gets uploaded as well into the database so we know to try and limit our prescriptions to them, and then have very real conversations with the potential threats. We see patients that die from these medications. And I think one of the really difficult things to deal with, and I'm sure Dr. Jasman sees this regularly, it's often not just one class of medications that patients are abusing. They're often mixing these with different other classes of medication that decrease your body's desire to breathe, and it kills people. And trying to create some awareness is difficult, and making sure that we have resources in the community to refer to help them get the help that they need.
What do we know about people who become addicted as far as traits? There are some people who say, I can't take an oxycodone or an Oxycontin because it makes me ill. I just don't like the feeling it gives me. And yet other people will continue to take them and then find they're addicted.
Right. Yeah, so it's thought that about 50% of the risk is genetic. And it's not a single gene. It's typically a number of different genes, and I'm sure we haven't even identified all of the genes. And then, of course, you have to have exposure to the drug, or you won't get it. Even if you have underlying risk factors, you won't get it if you are not exposed to the drug. And then another piece that's really important is people who have underlying risk factors that have made their stress response system of the brain abnormal. So this would be people who have underlying depression, anxiety, PTSD, mental health disorders, and importantly, a lot of persons who grew up and had adverse childhood experiences have these kind of underlying abnormal stress response. So you can measure this with like cortisol levels and things, that they are not, that part of the brain is somewhat dysfunctional. And that seems to be a risk factor for patients to feel more normal when they take these medications, because a lot of patients, when they take these medications, they feel awful. It makes them have all kinds of side effects and that sort of thing. But there's a population with some of these risk factors that when they take the medicine, they feel actually better, and they have the euphoria that has been spoken about. And so those people are much more likely to want to take it again because they felt so much better taking it.
Mm-hmm. Dr. Lutz, we know this to be a national issue, but what do we know about the numbers nationally, statewide, and locally, and the populations involved?
Sure. I mean, the latest data we have are primarily from 2017, and nationally it was stated that about 76,000 individuals overdosed on a variety of substances. About 46,000 of those individuals were opioid related. So, a significant percentage of that 76,000 were opioid related. But we also find, as has been mentioned, methamphetamine is another substance of misuse. And as has been mentioned, oftentimes it's polysubstance. It's not just one. We focus on opioids, but the reality is that people take substances of misuse or abuse to feel differently. And it's oftentimes to address the pain they're feeling. In Washington State in 2017, we had about 750 individuals, overdose. And so again, of that number, a significant percentage were opioid related. In Spokane, our numbers are less, but still significant. I think it's important to realize, however, though, that we are seeing improvement. So for example, with respect to prescriptions, and again, a lot of the blame has been placed on physicians for overprescribing. The peak number of prescriptions nationally occurred in 2012, and in Washington State it occurred a number of years earlier. And we've been seeing a decrease ever since then. Likewise, if I look at data from 2018 to 2017, I see decreased prescribing rates and, importantly, decreased death rates from all substances, including opioids. But where I am seeing increases are with methamphetamine, and then unfortunately with fentanyl, as we talked about. Fentanyl, a lot of times individuals don't know it's mixed in with what they have been using. And so all of a sudden they're used to a certain dose of heroin, and it's cut with fentanyl, and they're not expecting that. And that's when overdoses unfortunately oftentimes occur.
Chris, what do we know of misconceptions about this problem and opioids and prescription medications? There's a lot of information, and a lot of it's not true? So you must hear quite a bit of that.
That's a good question. Well, it's important for us to follow evidence. And so a lot of time, most people are very smart and are able to put 2 and 2 together, but they don't have all the facts. So sometimes we'll try to self-medicate with other substances, and we just don't have data on that. So that's a misconception, where they'll try to alleviate their symptoms with a herbal product or something like that. And also we turn to medicines maybe too frequently always for the treatment of pain. Alternative pain treatments are vital in terms of treating pain. And like at St. Luke's, we changed our script. It used to be when a patient complained of pain, we said, well, what is your pain scale? 0 to 10, 10 being the worst, and I'll see if it's time for your pain pill. So we want to shift the dynamic to say, we want to do everything we can to manage your pain. What have we been doing? What has worked? So maybe it's heat or cold or stretching or massage or relaxation techniques and the pain medicine. And so like we've learned with people with low back pain, the first trip shouldn't be to the pharmacy, it should be to the physical therapist, because we found that that's the best way to treat that issue. So I guess that's, I don't know if you guys have other.
I think it's really important, at least we see this in the emergency department, even patients with acute pain. We need to set a pragmatic framework, and I think patients have that expectation that they're going to take a pill and their pain's going to completely resolve. And I think it's really important to let them understand this is not going to take your pain away. I might be able to hopefully reduce your pain scale by half, but I think people have to realize there's no magic pill that's going to take their pain away completely. And as you escalate doses looking for that effect, you run into these significant complications.
Now that might be the average person, but what about somebody who has opioid use disorder? That could be a whole different ballgame. You're not going to reason with them.
Well, I see patients once they are typically wanting to have treatment. And so that's a little bit different scenario.
They're seeking treatment.
Yeah, they're seeking treatment for that. But when patients have opiate use disorder, but sometimes they are too ashamed or afraid or, to actually say that, so they might come in and say that they really are having pain. And that's sometimes a difficult thing to figure out. It used to be that we would be able to look at the Washington Prescription Drug Monitoring website and pick up a lot of these people, but more and more they're getting it from the street, and so we don't see anything to trigger that when we see them, and so that becomes more of a difficult challenge to find these patients and offer help.
Okay, looks like we have our first phone call of the evening from Alice in Alberta. Good evening, Alice.
Hi.
Hi, you have a question for the panel?
I do, and I'm really not sure how this question could be perceived, but I do know of someone that actually has had several surgeries, on up of 10 surgeries, and is on an awful lot of medication. Several of them are, you have mentioned on your program. One, of course, would be fentanyl, and the other is oxycodone. And then there are several others. And she has finally found someone to give her a new medication for her migraines. But she's been taking all of this stuff for years. And I'm wondering, how can it be that she's still taking it if some of these are just pain medications?
Now, are Canadian laws different from what we see in the U.S.? Because Alice is in Alberta, so I know you mentioned the computer tracking system. Could it be different there, that they're not monitoring?
I suspect not, and there isn't laws regulating this. It's up to prescriber recommendation. And so there are patients that are very appropriately prescribed these medications. So there's no physician, I suspect, breaking the law. I guess it's always a possibility there's unscrupulous providers, but I suspect probably the provider that's prescribing these medications feels that at the time it's in their best interest. But I think it's common where prescribers as well as patients can feel trapped, and they led them down this pathway, and then now they become dependent on the medications, maybe even to function and control their pain. And then how do you back patients away from that point? And that's why there's specialists like Dr. Jasman that are highly skilled at doing that. It's not an easy task, and it's a difficult conversation to have with patients. Very difficult.
Yeah. Where do you begin?
Well, I think some of it is asking the patient if they want more information. It's amazing how much more information we have now than we had 20 years ago in terms of chronic pain and what works and what doesn't work and what's dangerous and not dangerous. And a lot of times the public is not aware of what are the dangers and I think a lot of it is that there was this assumption, not only among patients, but among healthcare providers for a long time, that really the only thing that can help pain are opioids, and that's really not true.
And so now we're having to back away and introduce these other methods.
Right, right.
Yeah. So where does, once someone says, I need treatment, I want treatment, what is the course of treatment?
Well, there are 3 FDA-approved drugs for opioid use disorder, and they are methadone, buprenorphine, and injectable naltrexone. And I think, you know, just like if you're going to build a house, you have to have a foundation. The foundation for treatment is medication. We have known for well over a decade that these medications work. Methadone and buprenorphine have been shown to decrease the overdose death rates by 50%. And that's huge, and yet we still have had difficulty with the public and even medical practitioners buying into the idea that this is going to be a helpful way for patients to go. There's a lot of misconceptions out there, but medications have been shown to be very, very, very helpful. And once patients get on the medications, that's when you try and tease out, do they need mental health services? Do they need substance use services? But a lot of people try to get them into these other services before they're stabilized on a medication.
Mm-hmm. And then once they are seeking those services, Dr. Lutz, do we have enough available in our community to help the population that needs to be helped?
Yeah, that's a great question, Teresa, and unfortunately I'd say probably not. And I don't think it's unfortunately unique to Spokane. I think it's unfortunately an issue that we have nationwide. We have increasing numbers of individuals looking for assistance. We have fewer providers who are able to provide the medication, as Dr. Jasman said. That's key. And so if I can't stabilize an individual with the disorder, then it's very difficult to provide the additional needed services that oftentimes become aware when you start to address all the issues. I mean, these individuals are very, very complex to work with. And as Dr. Jasman mentioned, you can't help but really emphasize the importance of adverse childhood experiences. When you talk with some of these individuals, you look at multi-generations of stressors in their lives, and it's heartbreaking. It's heartbreaking to think that a society such as ours has unfortunately created this environment. People don't wake up saying, I want to be addicted, but they feel pain. And they're looking to try to address the pain. And what do they know? They know what they see, what they've learned. And medications address the pain, unfortunately. So long story short, we do not have sufficient needed services in our community. But again, I think that's something that we are working with collaboratively to try to make those services available.
What are some of the signs for family members to watch for if they start to become concerned about a family member that they can recognize as being a problem?
Erratic behavior. A lot of these patients don't act like themselves. They might be gone a lot. They might be sleeping. A lot of times they will use their drugs they have to find a place to use their drugs, and so you might pick up that there's needles laying around or something like that. Emotional ups and downs are very common. And yet, I have to say that I've seen a lot of patients that have been able to, use their drugs and even inject drugs, and close family members don't even know about it. And I've been surprised sometimes at the number of patients I've had that actually inject drugs routinely, that I have to look really hard to even find a place where they've injected. So it's not really obvious sometimes. Some of these things can be very, very well hidden.
Chris, you actually teach a class about medications and informing people. Talk about that.
So we have a pain program for injured workers, and so they come to St. Luke's for physical therapy to help recover. It's like going to a job 40 hours a week. Part of that is an educational component, and part of my class is apologizing for not having a medicine that works to help with their pain. A lot of the patients in the class have been on almost every medicine imaginable, and some of them aren't on medicines anymore at all because they didn't help with their pain and they had side effects. And so, but just having the education about how they work and why maybe they don't work, or why they worked at first, and as you build tolerance to them, the euphoria and or pain relief, you have to keep escalating the dose. And so the people that look completely normal that might have a steady level of opiate in their system is because they're tolerant to it. And the thing to remember is that if a medicine's not helping their pain, and they just take it because they start to feel bad when they don't take it, it's time to try to wean it off. And it's a very long, very difficult process that physicians have to help work through. I think they have a opiate stewardship pharmacist at Providence group that helps the different physician offices come up with a plan for weaning, and that's been successful.
I think it's one of those disorders where if you say, I'm going to draw this line in the sand and I'm going to wean myself off, it's nearly impossible. And I think what people don't realize that every degree that you feel great, when you come off of these medications, you probably feel tenfold worse in each direction. That euphoria is reversed, that pain is back, you're vomiting, you have diarrhea, you have chills and sweats, and you're not sleeping. Withdrawal from opiates doesn't kill patients, but they feel probably like they're getting ready to die. And it's incredibly difficult for them. And I think the trap with the opioid pain medications, when they're used for abuse potential, they keep escalating the dose, escalating the dose, escalating the dose, and eventually they lose that euphoria that they're getting. And they just need it at that point to function and feel normally, and trying to back off. You see it, and it really is pretty tragic. And I think with addiction, there's no societal bounds. There's no economic strata that's not affected by this. It affects everybody in every aspect of the community, and it's treated as, in a lot of instances, as a character flaw. And I think what we have to do as a society, it takes a community to treat this disorder, and we have to realize that this is a disease. It's a potent disease that's killing. And when Bob mentions overdoses, these are deaths. These aren't somebody that takes an overdose and falls asleep and wakes up. These are people that are dying. And the downstream effects is, think of the family members with that. Although we're losing 70,000 patients a year, multiply that by 10 with the number of family members that are affected by the loss.
Well, and as you mentioned, Dr. Getz, when you think of a drug addict, so many of us think of stereotypes, that will come to mind. But the truth is, anyone can spiral into addiction. Some people recover, some don't. Tonight, a story of hope from a man who pushed through his need for pain medication and is finding joy in the little things.
We are going down the river to throw rocks.
There's something about spending time with a 5-year-old that keeps you grounded.
It changes everything, as soon as he walks through the door, because he's 5 and it's unconditional love no matter what.
Whoa! Just ask Ray Sanderson.
My life revolves around recovery and Silas.
Ray is a surrogate dad to Silas, and a big reason, he says, for his sobriety.
July 2nd is my 2-year clean date.
Ray's journey into addiction began in 2010 with repeated trips to the hospital for stomach pain. Each time Ray sought help, he was given pain medication and sent home. Until one day, a new round of tests pinpointed the problem.
I had a football-sized pseudocyst attached to my spleen, my pancreas, and my stomach, and so they had to remove that. And it's a pretty invasive surgery.
Ray's surgery didn't heal properly. He lost weight and was in extreme pain. That meant more pain medication.
I took them more because I had myself convinced that I was in more pain.
Until one day, doctors cut him off. And just like that,
I went directly to street drugs because narcotics were no longer available. They got stopped for me, and it was less than a week that I went searching for street drugs.
It took a family intervention, treatment, and 2 relapses to get Ray to where he is today.
Here I am. alive on the other side.
Which brings us back to Silas.
In recovery, we say higher power. He is my higher power, you know, because he depends on me so much that I really, really need that connection with him.
The other place Ray finds connection is Recovery Cafe Spokane.
I do not do well by myself. I know that. And this place keeps me on track because it gives me something to do every day.
Looking back, Ray wonders if his doctors should have been more aware of the possibility that he'd get hooked on pain pills.
I feel like if they'd been asking those questions, that life might have been different.
But instead of being bitter, he's grateful.
I am so happy, so happy.
Telling his story so everyone knows it could happen to them.
Addiction has many faces, and with saying that, addiction is universal. It doesn't judge, it's not prejudiced, and it can strike anybody at any time.
Dr. Lutz, I saw you nodding quite a bit during Ray's story. Is his a fairly typical story?
I think from a lot of different levels. I think, you know, one of the issues we've seen that he mentions is that he was started on medication at some level appropriately, and then when it became a concern, he was cut off very drastically. And again, we hear that all the time. Dr. Jasman, unfortunately, probably hears that more oftentimes than she'd like to hear. It's been sort of this response where we're overcompensating, and we have to address the fact that we've created a problem with some individuals. Now that they're addicted, we need to assist them. As has been mentioned, medications work with that addiction, but to cut them off is like taking somebody with diabetes and saying, we're not going to give you insulin anymore. Somebody with heart disease and saying, we're not giving you your blood pressure medication. That's not the way to approach it. But I think until we educate providers that this is a chronic medical problem and something that can be addressed with medications and other services, then again, it's going to be a learning curve for a lot of us.
Mm-hmm. And he found a lot of relief and support with Recovery Cafe. Talk a little bit more about that program.
Yeah, so Recovery Cafe is wonderful. We have a lot of patients that go there, and it's a very warm and welcoming place, and so where people can be in recovery, and they can have recovery groups at various times of the day, and they take a lot of volunteers and teach peer advocates, so people who have been in recovery and then want to help other people into recovery, they teach them the skills that are needed for that. They do a lot of events in the area and that sort of thing.
Okay, we have some phone calls to get to. Cece, good evening, Cece, and thank you for waiting.
Well, thank you. Well, I'm listening to your program, and it might be that what I have to say, anyway, I'll go ahead and get it done. I'm upset with the people that are in nursing homes that are put on fentanyl, and they didn't ever was on it before, and I know some of them, and they weren't in that kind of condition, that they had pain. It could have been just from the old age. But when they get released, when they get out of the nursing home, then they're addicted. And then people that take care of them have problems of taking care of them, and they don't live long. But I just don't see Medicare is paying for most of the medicine that they're using in the nursing homes. And I just don't think that that's a way to stop this opioid problem.
Well, Cece, thank you for your comments. We really appreciate that. How true is Cece's story? Do we know?
I don't think we know the data on that.
No, I mean, other than the fact that if you look at vulnerable populations, the seniors are definitely, unfortunately, one of those populations. You know, it's estimated that about a quarter of those individuals who are long-term opioid users are seniors, and prescribed maybe medications for arthritis, and then again they continue to use and they continue to use. And I think one of the concerns is that not only for the individual, but then we also find that the concept of diversion. So they may have grandkids who come over and they look through grandma's medicine cabinet and they see these pills and they've heard about them, and all of a sudden they start taking them. And so again, I think that not only is it an issue for the individual senior, but also for family members. So.
But I want to comment about something she said about them getting out and then being addicted, because a lot of people equate dependence with addiction, and they are really very different things, although there are some patients that it's difficult to define which category they're in. But, you know, if anyone takes an opiate for a long period of time, they will get dependent on it, which means that you need a higher dose to get the same effect, or if you get off of it, you might go through withdrawal. But addiction is very different. It's actually a brain disease. It's a chronic disease that affects various parts of the brain, which actually have been identified, and there are clear abnormalities. So it affects a combination of the pleasure reward system of the brain, and then there's the part of the brain that is more the stress response area of the brain, and there's another part of the brain that's sort of more about judgment and about, you know, deciding consequences and deciding what's most important. So if in a normal brain, if you are eating your favorite ice cream in your favorite chair and watching your favorite movie, that's very pleasurable, and you might be there and really having a lot of pleasure. But if you look over and see a toddler is about ready to walk out into the street and could be in danger, your brain will instantly decide that pleasure is not something you want to deal with, and you want to go out and deal with the toddler that could be in danger. You don't even think about it. That's a normal brain, because the part of the brain that's responsible for making decisions and deciding what's important and that sort of thing, that is a normal, healthy, functioning brain, and it takes charge. But what happens when people in an addiction situation is that it's reversed. And the part of the brain that's supposed to be saying, this is important, we need to do this because there's long-term negative consequences, gets essentially shut down. And the part of the brain that is about pleasure gets revved up, and it basically becomes in charge. And this has been demonstrated. It is an actual brain changes that happen. There are chemical changes to the neurons, the nerve cells. And so then the patient, rather than being their actions being related to judgments and deciding what's the best course of action, everything is about, I have to have this pleasure. It's all about getting the drug. You have to get the drug. You have to get the drug. And then another part of the brain, which is the stress part, might pop in and say, yeah, and you better get the drug because otherwise you'll be in withdrawal. And so everything is reversed. Mm-hmm. And so it's an actual disease, and some of these people who get on opiates don't actually get an addiction. That's a different thing.
And I've never heard it broke down like that. That's very interesting. It's an excellent way to put it, too. I've never understood it to be that way, and the definition of the two. It's very good to understand it that way.
One thing to Cece's point, just I want to mention quickly, and I think, Cece, what you're experiencing, it takes a long time to train physicians in prescription habits. And we're still decades away from probably training the physicians in how they need to prescribe these drugs. I'm 13 years into my practice, and when I was training, I never heard of morphine equivalents when it came to prescribing these drugs. And I think what you're seeing now in medical training programs, there's much greater awareness among physicians prescribing these. And I'm hopeful that that will translate to less and less of the situation that Cece's describing in the nursing home.
Okay. We have Mike in Newman Lake. Hi, Mike. Thank you for waiting.
Hi, good evening. Thanks for having me, folks.
And your question?
I'm going to try to make this as brief as I can for you folks. I had injured my back originally in '95, have had multiple surgeries, some skeletal defects, birth defects, and I've been dealing with chronic pain and pain meds for 25 years. Every MRI I have every couple of years shows more and more problems. Every level in my spine, except the thoracic region, has issues. And from what I understand, the government has been sending out letters to doctors saying you have to drop patients down, you have to drop them down. And this has affected me in such a manner that I'm not able to go out and enjoy my daily life or even live it at that matter. I'm laying flat on the ground because of the pain. I've gone through when they've shut down the clinics, and I've been cut off for reasons like that, or the doctor would move and I wouldn't get my medical records. And never went through these type of withdrawals where I'd want to go and get anything from the streets. It's not easy the first few days, but that urge has never been, and there's never been anything in 25 years of record. Yet it's still so hard to talk to doctors, especially when they rotate in and out so much and build up a rapport. What can a person do, in your opinion?
Dr. Jasman.
Yeah, I
It's
see
a tough
that.
situation.
I see that quite a bit. And actually, there's a lot of patients like this who, and I don't know what dose we're talking about, but there's a lot of patients like this who have been, you know, put on opiates years ago for pain, and the dose was escalated, and they're often on high doses that are actually kind of dangerous, even at those levels, even without other medications in the mix. And we have found that a lot of these patients do better if we treat them with the same medicine, or a similar medicine, I should say, as what we treat people with opiate use disorders. And even if they don't have that diagnosis, because the medicines are so much safer and they relieve pain well, and they don't have as many problems if the person is also taking other types of medications, sedatives and that sort of thing. And so we've had a lot of success switching people over to that, and had a lot of people do well. So that is one strategy, is finding someone who can prescribe those types of medicines. And you usually find that in a place where they're doing addiction medicine. And some patients don't like going there because they say, well, you know, you're telling me that I have an addiction and I don't, but those are the people who are most comfortable prescribing those kind of medications. Those medications work for pain as well.
Which also makes me wonder, Chris, when somebody is prescribed an opiate for legitimate pain after a surgery or procedure, or whatever the case may be, what do they need to know? Because we may be striking some fear tonight, because they are still legitimately used.
They're very effective medicines for acute pain. And so there's new prescribing rules that limit a lot of the new prescriptions to just 7 days, which is a short period of time.
How many pills typically would that involve?
It depends on how many they should take, but they just do it in day supply.
Okay.
So the amount of time your brain, your neurons are exposed to the opiates is what drives our tolerance and dependence. I think the most important thing is probably the relationship with your doctor. If you follow their instructions and keep them updated on how things are going. If they give you a treatment plan and you decide that it's not working for you, don't wait until the next appointment to talk to them. When I say talk to the doctor, call their office, and you're not going to talk to the doctor because a lot of times they're so busy. But they'll have a note in the chart, and you're building that relationship with them, that trust relationship. And that's one of the things that's really important as you go forward, because oftentimes people break that trust relationship with the doctor, and that's hard for the doctor to navigate because they're prescribing medicines that could be dangerous if you misuse them. And we put the doctor in a box if we don't follow their instructions. So I think that the relationship, and the other piece is the availability of Narcan. For people who use not at a certain dose, it's really important for you to have that, and for your family to know how to use it. And it's a very effective medicine. It reverses the opiate effect, and it's a nice, safe thing to have just in case.
In fact, we haven't even explored Narcan yet. We know our first responders use it, but families can actually get it.
We're discharging patients from the ER that are at high risk for opiate overdose with intranasal Narcan to deliver at home, and we're trying to educate loved ones that are there with them how to use the medication, because it does save lives. I mean, it's dirt cheap, it's highly effective, and really it's something that everybody needs to be embracing in patients that are really high risk, whether it's because they're on chronic medications that, as Dr. Jasman mentioned, or at doses that may be unsafe, especially elderly patients, or if somebody that's battling with addiction in the community, they need access to this medication.
How does it work?
It's an opiate blocker, and it comes in a couple different forms. It can either be sprayed up the nose, or it can be injected, or there is a device you can get to put on the end of the syringe so that it can become a nasal spray. And it is just simple. If the person looks like, if they are obtunded, they're not breathing, or you can't arouse them, that sort of thing, then giving them this squirt up the nose and calling 911 can be life-saving.
Are there any dangers to using it on somebody who perhaps hasn't overdosed, or?
No. And if you think that there's a possibility that it could be an overdose, then that's the first thing you would want to do.
I think it's the challenge with fentanyl, is that fentanyl is so potent that sometimes it takes much more Narcan than we realize, and fentanyl overdose can be very challenging, and that why isn't this patient responding to the Narcan? Just need to give a whole lot more, given how tightly fentanyl binds to those receptors.
Can I walk into a pharmacy or request Narcan?
Well, that's what I was going to say. I actually, and again, a real credit to some of our local pharmacies and some of the national pharmacies like Walgreens. I've actually established what are called collaborative drug treatment agreements with Yokes and with Rose Hours. And so under my licensure as the county health officer, people can go in and talk with a pharmacist, and the pharmacist can determine whether or not that individual or a family member of that individual is appropriate for having a prescription for Narcan, and they can get that again at Yokes, at all the Yokes in the area, and Rose Hours as well. Walgreens has been doing that for a number of years. So we're one of about 41 states and Washington, D.C. that make naloxone, Narcan available through the pharmacies.
We have Phil in Spokane with a question. Phil, thank you for waiting.
Thank you. Hello.
Hello.
Yes, I have a very close friend that's been on OxyContin for over 5 years. 5 years ago, she was getting a massage on her back, and the person just pushed down really hard and crushed one of her vertebrae, and she lost a complete vertebrae in her back. She lost about 2 or 3 inches in height. And so since then, she's been in extreme pain every day, all day, and just suffering quite terribly, really. And she's on oxycodone, 10 milligrams, 5 a day is what the doctor prescribed. And for the longest time, she's been trying to, cut down herself, and she tries to keep with 4 if she can a day. But she's in all this pain, and we're watching the program tonight, but I'm in another room while she watches because I don't want you don't want the sound problem with on the phone talking to you at the same time. But you mentioned something earlier in the program about methadone would be helpful for something like that, but I don't know whether that one of those programs would work for her or not. I don't know what your thoughts are.
Okay. Is it an option?
It is. A methadone can be prescribed for pain. You cannot prescribe methadone for opiate use disorder unless it's through an opioid treatment program like we have at the health department. But you can prescribe it for pain. It used to be prescribed a lot more commonly, I would say, than it is now, because there are some very significant risks associated with methadone for pain. But that doesn't mean, couldn't help some of the patients that are out there. I tend to go more toward the medicine buprenorphine because I think it's safer and it's easier. You can get it in a lot of different, in terms of for opiate use disorder, at least you can get it at a doctor's office as opposed to just going to the opiate treatment programs. But in this case, it'd be difficult to say without knowing what all the other factors are, what the appropriate treatment plan might be.
Certainly questions to ask a doctor.
I think it's okay for her to ask her doctor for a referral. They're just for maybe a second opinion. You'll think of it as not to demean or insult your personal doctor. But if you ask, my pain's not under control, I'm worried about the medicines I'm taking, or what is my plan? Do you think we have other things to do? And then if they are amenable, then I think it's very wise to ask for a referral to a pain specialist, and they can pursue other things.
Start to explore some other options, at the very least. We have Mike in Spokane. Hi, Mike.
Hi.
You have a question?
I do. My question is, I'm on hydrocodone 10s, 325s, and I have not had a problem with opioid use, overusage. My doctor wanted to increase my dosages up to, like an oxycodone, but I refused to go to that level. And now that I'm under this pain contract, I feel like sometimes my doctor looks at me like I am a drug addict, and that's farthest from the truth. But I have degenerative disc C3, C4, and joint pain, and I'm wondering what we do to otherwise kill the pain than going through more opioids.
Dr. Jasman?
Well, one of the things that we've learned over the last few years is how important other factors are to pain. These would include things like how important it is to have good sleep, how important it is to monitor your mood and be treated if you have underlying anxiety or depression or anything like that, to move more, to exercise more. That's huge. And what we found that it's really a biopsychosocial, spiritual kind of model for treating chronic pain, where pain can be much, much, much higher if, for instance, the person is depressed. And treating the depression can cause the pain can go down. Pain can be much higher if the person is focusing on the pain as opposed to focusing on life's goals or things like that. So it's a much more complex situation than just the pain itself. And a lot of other factors can contribute to improvement of the pain.
What's the best thing for someone? A lot of family members will say, well, just stop taking the medication. Just throw it away. You just simply don't need it anymore. That's not exactly the way to go in a lot of cases. It won't help.
I think, there are people that can certainly stop when they're short using, and if you're not having severe pain, don't take medication that's for severe pain. Never throw it away. We can take it to local pharmacies, you can take it to your local hospital, and they'll dispose of it safely for you. But I think people have to be mindful of the amount of pain that they're in, and if they're on a schedule of taking something every number of hours and they don't feel like they need it at that point, and this is a medicine for acute pain, push that back and see if you actually need that. See if something like ibuprofen is a better alternative, or just acetaminophen, Tylenol. Because we're guessing. When I prescribe you that medication for a broken bone, this is what I'm guessing is your requirement for pain. But if you don't need to take it so frequently, please don't. I will not be offended.
Dr. Lutz, go ahead, Chris.
One of the resources is Take Back My Meds website. The Sacred Heart Hospital and Holy Family Hospital, their ERs have a drop box for medications that aren't needed anymore. And so if you are done with the acute pain medicine, it's good to dispose of it properly so it's not around for someone to find and misuse. What will you save it for? Why would you keep it around to be misused? But I think that the Sacred Heart and Holy Family, they've had 800 pounds of medicines returned so far.
Wow. Dr. Lutz, what can we do as a community to help to solve this problem, this epidemic that we're seeing?
Well, I think one of the great things we're doing is, for example, being here. We need to raise awareness. We need to raise awareness of not only the issue, and I think more and more people are aware of the issue, it is a crisis, it is an epidemic, but also the stigma associated with it. We have to acknowledge the fact that these individuals who have this chronic medical condition have a chronic medical condition. And it's not the moral failure that unfortunately many of us were taught to believe, and that unfortunately many people still believe. So the stigma is huge. Then we also have to look at resources. And we have to be able to identify resources. So once Dan and his colleagues in the emergency room identify an individual who needs help, we need to be able to get that individual into a facility in a timely fashion, because you've got a window of opportunity. And if you don't take advantage of it, then that person may be back in Dan's ED with another overdose. So I think it really is a collective community effort. making more resources available, working with individuals, providing family members awareness of what to look for and then what to do with their family members.
And this community has a task force that addresses this issue on a regular basis. What is the work like there?
So this is one of the things, trying to get people talking about it. And there's going to be another training this Saturday, actually, that's most of the day, and it's a variety of different topics for providers, and I think that's going to be a big part of it. And just kind of learning from each other what works and what doesn't work. There's a lot of benefit to bringing the community together and talking about where the resources are, where people need help. For instance, one of the things we've seen with our patients is that patients with opioid use disorder are a lot of times have been shamed by their family, by their friends. So they may not have family that are supportive of them anymore, and they are just kind of fearful to even seek help. And then once they do seek help, they are fearful of like if we were to refer them to substance abuse treatment, they may not even want to go there because they're afraid how they might be treated or something like that. And so, having somebody come along beside them and help them get from one place to another can be really helpful. And we share these kind of things with each other and try and figure out how to strategize to help.
Well, it's certainly a topic that we've just barely scratched the surface on this evening in talking about it and addressing it. But again, the conversation needs to continue, and it's the only way we're going to start to solve this problem. And I want to thank all of you for being here tonight to help us understand what we're talking about and make some headway in addressing the problem and solving it in our communities. Thanks so much for being here. And that is going to do it for this edition of Health Matters. If you would like to learn more about tonight's topic, we have posted some links to all kinds of resources on our website. Just go to ksps.org and click on Health Matters. And we will be on a summer break for the next few months, and we will see you again in the fall. I want to thank you all for tuning in tonight. Until then, thank you. I'm Teresa Lukens.
Health Matters is made possible by our viewers, the Friends of KSPS, and by Providence Healthcare.
I'm Arnie Peterson, and I'm an orthopedic surgeon, and I work at Sacred Heart for Providence Medical Group. When I needed my hip replaced, I chose Providence because of the professionalism and the care that I knew I'd receive. I never thought twice about going anywhere else.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?